up to 13,000, and now I'm sending like 15 max Gmail accounts to all these groups. So instead, we're just going to keep posting on the website every week, and we will post where we are for Journal Club each week as well, so everybody knows. In general, we're going to be going back and forth between North and South Jersey, unless you want us to come to where you're located. And of course, in the second half of the year, we travel around a little bit throughout the state. Go on our website if you don't know for the 50th time, www.emsfellowship.com, and we have some new sections on there as well, and we keep updating it. And we're going to get started with Journal Club. As always, if you have any questions, please feel free to text them to us. No, is that the right word? Email them to us. Facebook them to us.
You can comment.
Message. Or comment.
Comment them to us. So, and we'll try and answer them in real time. And even if you disagree with anything we're saying, please let us know, because that's the way we're gonna learn as well. Okay, we'll get started. So we'll start with the usual interesting cases. Who wants to go first?
I had a pediatric cardiac arrest this week. The call when I got pulled off of another call. I was transporting or going with EMS to the hospital with a different patient, and they called me off of that to respond because the nearest ALS unit was a little ways away. And unfortunately, from what we can glean from family, the patient was 2, and he either was given some tea or water that was hotter than they realized, or he grabbed somebody else's cup of hot tea or water and proceeded to drink it and suffered like 2nd-degree burns around the mouth and on his chest. And it's a little bit unclear if he had airway edema and swelling as a result of like the caustic injury, or if he had like started to throw up and then aspirated. But regardless, at some point he entered respiratory and or cardiac arrest. And so it was unfortunate ending, but I think we did everything that we could have. We secured his airway on scene. There was excellent CPR. We got an IO right away. Followed the PALS protocols in terms of arrest. He was in asystole the entire time, except for one maybe 2-minute period where we had PEA, one round of CPR where we had PEA. So, I'm not sure that I would have changed anything about how it went.
Yeah. So, we do all this stuff that doesn't work very well. We put the IO in, right? We did that probably before you tried peripheral access?
So they initially tried the peripheral. They were going to, and I said, don't do that. I would do the IO because it's faster, and we have to get some sort of access going on.
And what size tube did you put in?
4.5.
All right. Did you follow the old 16 plus age divided by 4?
Yeah, age over 4 plus 4.
Yeah, whatever. Yeah. So you did that, and what size? What blade did you use?
I ended up using a 1, a Miller 1. A 0 was a little bit too short.
Okay.
So.
And there was no air leak in the tube?
Not that I could perceive, no. But it was uncuffed, and
right.
So
right.
Probably a little bit, but.
And then I know you ultrasounded the kid in the ER, and there was basically no cardiac movement.
Right. Yeah, they only got ROSC in the ER for about 60 seconds. And then
after a lot of epinephrine, probably.
A lot. They had actually started an epi drip at that point. He had gotten 6 rounds of epi in the field before we got there, and then they started to drip when we got there, and then he unfortunately bradyed down again below 60, so we had to start CPR, and then the next round they just.
And who knows? There's probably no benefit to doing an epi drip, but at least if you forget to do repeat boluses of epi, at least if you're in an ER, I guess it's okay.
Yeah.
Certainly in a pre-hospital setting, we don't resuscitate people on drips. We always say that, right? So we try and give repeat dose of epi. The good news is before the recent trial came out about epi, there was no clear benefit anyway that we believed on repeat dose boluses of epi, no matter what. It leads, you do get more ROSC as you did, but you don't change survival or a good neurologic outcome.
Right.
But that's the only drip, Tanis can speak to this more, the only drip we resuscitate with pre-hospital is D10.
Right.
Which is now the only exception outside of that, you're right.
Right.
We've done push dose epi, push dose nitro, push dose everything. But yeah, that's one of the few exceptions, because I was like, yeah, that's right, I can't think of an occurrence until And D10 is the only one
We
where.
should probably be pushing D10 too.
Yeah,
So
I was
there's
actually
more
thinking,
come.
why can't you bolus D10? Why can't you take like a big 60 ml syringe and just push D10?
We should.
Yeah.
That's more study. They did it in Aliquots and push it.
Yeah, like that would make sense. I mean, the drip that you're. Somebody asked me, one paramedic sent me an email this week about. He said, how much D10 do you want us to give to these young kids? So what's the answer?
So it's a gram per kilo.
Whatever you need.
Well, there we
Yeah.
Yeah.
Right.
As much as you need to get.
Well, this was a
Gram to half a gram to a gram per kilo.
right. So I mean I like half a gram per kilo to start with, but certainly then double it. So half a gram per kilo, and then D10
And with
is
the D10,
D10
every
is how
5
much
grams.
dextrose?
So it's every 5 grams is 50 mLs. So
Right. So D10 is just 100 milligrams per 1 ml, right? Like D25 is 250 milligrams per 1 ml, right? So because D10 is 10% dextrose, and this works for everything in medicine, right?
yeah.
Take the percent, cross it out, put a 0, and it's milligrams per milliliter. So you take cocaine 4%, cross out the percent, add a 0 milligrams per ml, and it works for every drug in medicine, right? So if D10 is 10%, that's 100 milligrams per ml. You give 10 mLs, it's 1 gram, right? If you're giving a baby half a gram per kilo, you can just figure out how much you need to push. But you can guess, I mean, right? And it's,
Sure, it's titratable.
right. In adults, we just give a bunch, and right, that hasn't worked out well for us. Right.
Everything should be weight based, and it's not
Right.
in adult medicine.
Right. All right. So that was the case. So what's the next case?
So the next case is a case that Tanis and I had last week. It was we were called to a 35-year-old lady who was found unresponsive outside of her home.
Are your residents watching it, by the way?
Maybe.
Do you want to shout out to them or anything?
I don't know if they're watching right now, but if they are, then hey guys, back in Miami. So we were called to a call to the scene of a 35-year-old lady found unresponsive outside her home. And police were first on scene. They administered a total of 3 doses of intranasal Narcan. And by the time we got there, she was still unresponsive. So they said that we got on scene, she was definitely still agonal. We decided to administer another dose of Narcan, actually nebulized. So 2 milligrams of nebulized Narcan. She still didn't come around, and so now we were, getting an IV, getting her ready to transport, getting her into the ambulance. And at that point, she still hadn't come around. We got an IV started. We started some fluids. Got an initial blood pressure, which I think was in the 90s or so, 90s or so, yeah. And so we're just kind of doing some resuscitation, and then we decided that we needed to intubate her. So-
You're not about to conclude that you gave 1 more dose of naloxone and she woke up, are you?
No,
All right, thank goodness.
no, we're not.
All right.
And so we got everything ready. We got the suction ready. We got everything prepped, and we gave her 200 milligrams of ketamine and 100 milligrams of rocuronium, and intubated her. I used a bougie because I love bougies.
You gave at least 1.2 mg per kg of rock. What was her blood pressure?
It was like, after resuscitation, she was probably a little like 100, or her pressure got better, I think, before.
So she was on the low side. So you're giving
On the
a higher
lower
dose
side,
of
yeah.
paralytic, because with hypertension you give a higher dose of paralytic, so you're giving somewhere between 1.2 to 1.5. A lot of people like to go higher.
Yeah, stick to round numbers in the field. It's
Right.
so much easier. 200, maybe 100. I think we gave the same dose.
So the one thing we know that too little rock is not good.
Right.
Right. So just like too little sucks is increase your risk of hyperkalemia. Rock works just as quickly as sucks if you give a good enough dose.
Mm-hmm.
I think, yeah.
So you gave both. You RSI'd her.
Mm-hmm.
Pretty sure it was 100. I think it was 150 of each. We gave the same dose for both.
Okay.
So
Okay.
yeah, we were shooting
Sure.
2 per kilo on both drugs.
Okay.
So she was about 75 kilos.
Okay. And then so intubated her DL,
and I guess we could have used video, but we just didn't have it.
First pass with bougie, very small.
Yeah, I mean, I could have used
So do you
DL, but
intubate everybody with bougie?
I do.
You do. Have you always done that?
No, I have not.
So and so you were a paramedic, right?
I was an EMT,
EMT.
basic. Yeah.
So do all of you guys always intubate with a bougie? Well, so we did. I mean, for those who pay attention, we did a clinical protocol about this, about the benefit of using a bougie, and there is some benefit, right? Like overall, there is some science about it. But in real life, do you guys use a bougie every time you intubate? So, use a bougie every time you intubate?
No.
No.
No, not every time.
You do.
I do.
No.
No.
No. No.
Drew?
Nope.
Nope.
Don't need it, but I do make
I
sure
am-
they go grab it.
Yeah, I
because
always
no one
have
can find it when you need it.
Yeah, I
So
That's
I make
true.
sure it's ready.
That's true.
So
I am-
I will say this, like,
I'm an island.
at least in our residency, what I do is one of the most important things I always tell people is how good is your backup airway if you haven't used your backup airway enough.
Right.
And so most people aren't comfortable using a bougie, but they grab a bougie every time in case their direct doesn't work. So my question to you is how comfortable you are with a bougie, and how many have you done with a bougie in order for you to say that you can use it as a backup when your one level of expertise, their go-to, isn't working. So I always have, nowadays I always push my residents to use a bougie or use a Miller, something different when it's an easier airway, so that way they can have the experience and exposure. So, and most of them do, and I think that's where it comes to, is being comfortable and using different modalities of airway management.
Do you use a bougie because that's what was taught to you as a resident? Like, do all
No.
the residents in your program always use bougies?
No.
No.
We were taught just regular, styletted tube, everything. I use a bougie because I like it, and because I've read studies. I've read the first pass bougie articles about increased first pass success with using bougies, and
Right. Do you preload it with your endotracheal tube?
no,
No.
I do not.
So, so I get what you're saying, but when you put it when you put in your laryngoscope and you see the cords, don't you ever just say to yourself, "Man, I could just take that tip of that endotracheal tube and pass it. I didn't need to do that extra step."
Yeah, that's probably true. In this particular case,
Because that's what older people would say.
Yes.
Right? Who've been intubating a long time. They would
Yes.
say it's an extra step. Although there are studies to say you increase first pass success, I agree with that.
but at the same time, from what I've noticed, is it doesn't add that much more time.
Right.
It might add 10 seconds, but then you get the benefit of always essentially using your rescue all the time. So even when you get to a more difficult airway, I know I can get it even on first pass.
Right. And you
Or
can
at
do
least
that
I have a
whether
lot
you're
higher
doing
success.
DL or VL.
Right.
All right. Interesting.
Of course, if I'm using a glide scope with a hyperangulated blade, I don't use a bougie. It has to
Okay.
be a Mac blade, a regular Mac blade, or a Miller.
Okay. And you probably wouldn't use a bougie, I guess, if you were doing like an A-view monitor with a bronchoscope. You probably
Right.
wouldn't. Or a single lumen tube which has a camera on the end.
Mhm.
Right.
Mhm.
All right.
Yeah.
Any other thoughts about that?
I mean, I think to tag on to what Tagore said, I mean, you're only as good as your backup. If your primary modality fails, I think that was something that I'm grateful my attendings during residency taught me. Was I had multiple attendings say, "What do you feel most comfortable with intubating?" And I'd say a Mac 3, Mac 4, whatever it was, and they're like, "Okay, good. You don't have that. Pick something else." And then that's how I was taught in residency. It was great. I thought it was a great thing, which goes along to the point where now if I needed to use a Miller, I mean, Janae just had to use a Miller pre-hospitally the other day. Probably not something she does very frequently, but I'm sure she's trained well enough, and obviously it was successful, so she knows how to use it. And same thing, I've been able to use Millers. I've been able to use glide scopes, light ones, LMAs. I mean, that's another thing that we don't use frequently, LMAs, but pre-hospitally we may have whatever supraglottic device, LMA, king tube, iGel, whatever it is. In the hospital setting, if you're working in the ED, you may only have an LMA, and if all you've done is king tubes, yeah, theoretically it should be similar, but
Yeah.
it's still a different feel.
You guys all went to, I mean, I'm looking at you, you all went to different residencies. So what were you taught about when to use a bougie? What were you taught?
Basically, as rescue, and really most people didn't use it. So if they had trouble, then they'd go glide, and if they then had more trouble, we had intubating LMAs. A lot of times the bougie was skipped over, and it was kind of my own
So you were intubating LMAs.
my own volition that got me.
And what were you guys taught about when to use a bougie?
We really weren't taught to use a bougie. We, for some reason, where I was trained, they want everything to be done with GlideScope first. So we used video as our first attempt, and our backup was actually direct or an element.
Yeah. I mean, the potential problem with that is you may wind up in an ER with no VL, although I
Right.
guess in 2018, are there ERs now with no VLs left anymore?
There must
but
be.
sometimes,
There
but
has to
sometimes
be.
they're broken or they don't have.
Right, that's
you
true.
don't
Sometimes
have
they're broken.
You can't
Or in a
find.
closet.
Right, but if you make that argument,
Can't
can I make
find
the
the
argument
or
that
whatever.
you shouldn't put centralizing with ultrasound machines because you can go to an ER where there's no ultrasound machine and you could just be doing blind central lines like we used to?
So it's funny that you bring it up. So I was just talking to our resident rotator, Dr. Del Maestro, who's with us, about this very similar concept. In military medicine, part of our clinical practice guidelines in terms of resuscitation are to use subclavian lines as our first choice. You're not going to do that. I mean, some people can do it with an ultrasound. I've tried. I don't think it's helpful. But thankfully, I trained in a place where we did a lot of subclavian lines.
So
Thankfully.
is that a John Holcomb thing? He's teaching you, so he's telling you
That's-
to do a subclavian blind as a first choice.
So for burn and I actually sent him a picture of it because we were talking about it. So the joint trauma, joint trauma guidelines, the clinical practice guidelines from the U.S. Army Burn Surgical Research and Burn Institute, whatever it is, specifically talks about the primary mode of resuscitation for intravascular devices is subclavian central line, with the backup being internal jugular. They don't really even discuss femorals whatsoever, but
My
they
surgical attending, just to back you up, said the same thing.
my trauma, same thing.
When I was at Einstein, the guy who ran the SICU is when you're in resuscitation, the line was a subclavian.
Yeah.
If you put a femoral line in, he was on your tail the next day. Because in his experience, most femoral lines that went in a code ended up in the artery, and you're blowing
Right.
tons
Well,
of levofed in somebody's artery.
so let's also be clear that we believe you don't put central lines in a cardiac arrest, right? Because it serves no purpose.
Right.
You want
Right.
to put an IO in, but to have an open big needle at a cardiac arrest is an academic thing that increases your risk of needle stick. And put the central line in after you get ROSC, if you get ROSC. Definitely different from a resuscitation where the guy may be in septic shock and not in cardiac arrest, and then you need to give volume, so you're putting in a central line. While maybe you're doing just an IO, which you can only stay in so long anyway.
Yeah.
Really? So,
This
so
guy's go-to is a
Yeah.
subclavian.
Yeah, that's
Same
what,
thing.
That's, I mean,
Same thing at Rider Trauma because it's probably at Army.
everywhere I
So
an army
subclavian cordis?
Was your first.
So
Yeah,
it's the
essentially.
Joint Trauma System from the Department of Defense Center of Excellence for Trauma, and that is exactly what it says in their guide.
So, I mean,
And
theoretically,
guidelines.
you know, you have, I mean, a femoral line's a dirtier line, although there was that study, which I believe was in New England Journal of Medicine, which we reviewed maybe 2-3 years ago,
Right.
where there was no increased risk of infection of femoral over IJ or subclavian, right?
Right,
Let's say
right.
that. Now, some people, depends if you're a glass half full or glass half empty person, would say, well, I could take any line and make it just as clean as the next one in the right situation. But that perfect situation is not what we do in real life. And in real life, femorals are dirtier, even though they published a good study to say it wasn't in that study. Well, I get that. Like, femorals probably are dirtier in real life in when people aren't thinking about it, and we're never as good as the study. So, but I don't know. I mean, so tell me what's wrong with the right IJ. Because certainly, if you need to float a pacer in your resuscitation, you either should go right IJ or left subclavian, a straight shot into the heart, right? So,
These guys were left subclavian.
so now you,
Put anything through it.
so they were telling you to put left subclavians in. They would teach. Are they teaching you, Ariana, to put left subclavians in?
That's
in case you
what
have
all
to, in case you have to float a pacer wire, then at least you're having a
So-
straight shot into the heart.
So in our trauma center, they would never float a pacer wire. So no, this is this is
Because it's
particularly
trauma.
for trauma, just because
All
it's
right,
a septic
so it's only for
hospital.
trauma, not for septic.
No,
cardiac.
for that it's right IJ. Is
And these were
Right IJ. So, and then tell me, so it's right IJ for medical resuscitations and subclavians for trauma.
Mhm.
And why are they telling you subclavians for trauma as opposed to IJs?
I was told that it's universally always open. It doesn't usually collapse based on their blood pressure. It's usually, the word he used was stented open or held open by the anatomy in the chest. But,
All right, so I guess I get that.
Yeah, and it's also
That was his
just
reason.
based on ease. All the patients that come in for us, they have collars, so you can't get to the IJ.
Okay, so
You know.
all right.
And that goes back to the modality of choice is ultrasound guided, ultrasound guided central lines. But if that's the go-to, something with video laryngoscopy, when you're in a place that doesn't have that as an option, are you going to be prepared to do it? I mean, when I would work in rural hospitals in Oklahoma, there were some hospitals that if you asked for a central line, they looked at you like you were out of your mind. They've never seen one, they've never heard of one. A glide scope or any kind of
Be
video
careful
device.
driving through that neighborhood, right?
Well, yeah, and that's the thing. I mean, it was a joke amongst the residents that people would love to moonlight there because you'd sit there and pick up a 24-hour
I
shift.
picked the right day to come.
What's up, man? So you'd pick a 24-hour shift and you'd see 3 patients in 24 hours. So, but nonetheless, I mean, there are hospitals that exist that don't have ultrasound, they don't have video laryngoscopy, they don't have central lines. So I think it's good going back to like what Tagore said is being well versed in multiple modalities, just in case you end up somewhere. If you always want to be at the Ivory Tower big academic center, then okay, but you may end up somewhere else.
So one of the people who's watching us, I want to know what they do in other programs too. So, geez, now I'm really confused. I mean, do we not believe that subclavians have a higher risk of pneumothorax than IJs?
His comment was if you didn't put a chest tube in for a failed one, you didn't do enough lines.
Please.
This is what I was told.
All right. So with that
Sounds like a
classic,
surgeon.
with that classic old saying, how many times have you guys caused a pneumothorax from central line insertion? I'm just curious.
We just had one last week.
I've done one.
I have
So
not.
zero,
No,
zero,
One on a
one,
subclavian.
Zero.
one on a subclavian, zero on an IJ. Ron?
Zero.
Zero ultrasound.
So
ever.
it's an old
Zero.
saying, right? If you
Yeah.
haven't caused pneumothorax, you haven't done enough central lines. I don't know that's true. Maybe that's not true because we're doing ultrasound guided.
That's the days before ultrasound.
Yeah.
You were using your fingers and palpating next to the carotid and using the little 25 gauge finder needle and then putting the big one in,
Right.
which we don't really do anymore.
And then depending on
Hopefully
how you
not.
move the head, the artery kind of
But
moves around.
this speaks against doing subclavians if it really is a higher risk of pneumothorax. But I mean, I used to do lots of subclavians when I was a medical resident, and I never caused a pneumo, and I didn't know what I was doing, right?
Yeah.
And I was digging around. I don't know, maybe I just got lucky that I didn't have any COPDers with, the apex of the lung, like up here,
Right.
I don't know.
Just gotta stay shallow.
Yes, they should. I mean,
Bounce it off the rib.
Hit that rib.
yeah,
Yeah.
And
then
walk
bounce.
it down.
Yeah.
But
Right, but again, for all the people who are doing central lines that don't know what they're doing on their first attempt, and they're not walking along the rib when nobody's looking, how often are they causing a pneumothorax in real life?
I got lucky. I got to practice my first subclavians in cardiothoracic anesthesia. So even if I dropped a lung, they were opening the
Chest is
chest
open.
anyway. So
Yeah.
maybe I did drop a lung. I don't know. But
Right.
I was lucky enough that that's where I learned my subclavians. We probably did 20 plus subclavians on anesthesia.
yeah.
Interesting.
So we did a ton. It was
Once-
great.
Once you get enough in, it's very easy.
And that's once you do it enough and you know kind of where how close the subclavian vein lives underneath the rib.
Yeah, it's right
It's
on.
easy after that. Yeah, which is right there.
Right.
Makes it very easy.
All right, so keep going with the case. So you gave a lot of naloxone, nothing happened,
Yep.
so you're RSI.
But the reason we RSI was she wasn't
She
controlling
was-
secretions.
yeah,
right?
she
It
was
This is co-ingestion.
full of
She was more than
secretions and-
one tox on board.
Definitely. She
She was
reeked of
heroin and alcohol, and
And how much naloxone did you get?
she got a lot. So she got 2 doses of the 8 milligram job, and then they got.
Let me get 2.
Yeah, so she almost got 20 with, so 4, 8. She got over 10.
So we proved once again more is not better.
No.
And some percentage of naloxone, which is ill-defined in literature, actually gets to the brain. That one article that we looked at said 4% gets to the brain. When we cross-referenced it, it was a terrible cross-reference.
Yeah.
So we don't really know. So some amount gets to the brain when you give it, but it's probably a small amount.
She was breathing better, but she was still a ton.
She was, yeah, she was
So you think she's
very
getting
much
better from naloxone?
Her
She had co-injection.
respiratory status was a little bit better,
Right.
not
So
fantastic. She was not hypoxic at any time.
She was a mess.
and then what else did you guys do for her?
So, other than just some resuscitation, I know we had some push dose epi just in case
Because of her blood pressure.
because
Because
of her
her
blood
shock
pressure and her
index.
shock
Yeah.
index. Her heart rate was
Right.
140, and
So
her blood
anytime your
pressure
heart
was-
rate's higher than your systolic, you're not doing well.
Yeah.
So she had a bad shock index, and
Mhm.
you didn't give her any push dose pressors because she ultimately didn't need it.
Right.
And then did you? Then ultimately, what was wrong with her?
She was just
I think
metabolized
she was just
to consciousness type thing. She just had to get over her intoxication.
Okay. So she was really, so it was all ETOH?
We
I think it was a mix.
I
because
think
she
so.
had heroin and drug.
She had
paraphernalia
obvious,
on the scene.
she
That
had
was cleared by
obvious
her
bleeding
friends.
marks.
How do you know when to intubate somebody who's intoxicated? I remember when I was a paramedic, this woman named Sue Dunmeyer, a famous ER doc who was at University of Pittsburgh, used to say, if you can take a laryngoscope blade and put it in somebody who's intoxicated in their mouth and they don't do anything, it's time to intubate them.
It's called
She was-
intubate
she
those
was
that
out
allow
there.
you to intubate them.
That kind of, I
Yeah.
mean, it's a very
Makes sense.
simplistic way of thinking it.
Reflex. You can't protect your own airway.
It's very
That's
common.
why
She was,
the
well,
OPA
she wasn't controlling her secretions.
But you think about it,
Yeah.
how many
She
people have you
wasn't
seen?
swallowing, she wasn't coughing, she
Right,
had
but how
nothing.
many people have you seen incredibly drunk, and how many have you intubated?
So
I've had
I-
patients brought to me intubated.
Brought you
Were
intubated.
drunk and then they were awake and fighting, biting the tube right away
Yeah.
as soon as we got there.
Right, did they need to be intubated?
Probably not, but it was probably, unless, you know, they could have been a danger to themselves at the time, out of
And-
Yeah,
control.
you don't know what the.
Because how you treat intoxicated people in 2018 totally depends upon what ER you show up at. It does not
Right.
depend on any protocol whatsoever, I'm convinced that. Some ERs will try and intubate you, put a Foley catheter in you, put IVs in you, and other ERs will put you like in a jail cell, and they will not put any IVs in you when your alcohol level's 300-400 plus, and do absolutely nothing. It totally depends where you show up. If you're in an ER that sees lots of drunk people, then you're probably a minimalist. If you're in an ER that sees one drunk person every year, you're a person probably getting a Foley and getting
Where's
tubed.
that ER?
And
I know.
right, they exist. I mean, you know,
Let's
when
go.
these college kids come in with acute intoxication, I've seen this, that nurses who put in Foleys and IVs before I could get in the room.
Yeah. I mean, it just comes down to time dependent of them getting back. So if they can survive the time it takes to metabolize their intoxicants until they're well enough, they don't get intubated. But if they're at a point where they're unable to control their airway, unable to, you know, manage, it's time to intervene.
So I use a couple things. Personally, it's for me. It's like what Jim talked about was like pooling secretions, vomiting,
Yeah.
and then my second thing is my pulse ox, whether or not it's refractory to a non-rebreather or a nasal cannula, and then most importantly, on every intoxication, I really try to use end-tidal.
Me too.
And end-tidal really is the end-all say-all for me. And if you're retaining, you buy yourself a tube. If you're not, you've got good end-titles, you got a good pulse ox, and you're just hanging out with a GCS of 3, I'm okay with that.
It's reversible conditions.
Right.
If you can reverse it rapidly,
Absolutely.
go for it. If you can't and they're not holding their airway, it's time.
I have a question for you. So are you, because I brought this up the other day and it seemed like a foreign idea to one of my residents about like just leaving the patient on capnography as they sobered up.
All the time.
Oh, I do that.
Yeah,
I
all
do
the
that on
time.
movie. Oh,
So
yeah.
at what point do you say they don't need that machine anymore, I need it for somebody else?
Yeah, as soon as you need it for somebody else and then you've watched it for 5-10 minutes. I mean, again, remember, the acute presentation is probably their highest level of intoxicated state. So if you can actually say that they're ventilating perfectly fine, they've got a good end-tidal, and I'm not really too worried about them at this point, most likely, unless they're sipping on some sauce while they're still there, they're going to be okay. Which happens a lot.
And if you don't have the nasal cannula and tidal, I assume you just take the two-piece and just cut it and put it in a non-rebreather or put it in their nose. So everybody's
Right. You can do an OPA, and you can shove the tip of the cannula actually right through the
Yeah.
OPA all the way down to the posterior pharynx, and you can actually measure it that way too.
Right.
That's another thing I'll do in a lot of these patients is always put in a nasopharyngeal airway, just
We did.
as long as they're.
Something very
She did not like
underutilized in pre-hospital care, I'm not sure why.
I don't know why
It's the
either.
old double nasopharyngeal airway, right, Jim?
Yeah, it's both therapeutic and diagnostic.
And it's even...
Yes, true, exactly.
That's what I
And
put.
it's even like in the PHTLS book, right?
Like for pseudosurgery.
Okay.
It's not even
Yeah.
like severe.
So don't carry it around.
Yeah.
I don't know why we don't do that, I don't know why we don't do that more. But what's the highest can anybody beat me the highest alcohol level you've ever seen?
516 in where we work the other day.
Yes.
Guy was a professional,
I think
and I was
At
impressed.
486 there. That's the
595.
highest I've ever seen, and it was the
This
same
was-
place.
this
and
was
he's
595, anyone?
talking.
this was not my case, but this was, we have a wall of fame in our resident lounge. I think someone had like 612.
The highest one, Presbyterian University Hospital, 760.
Gee.
Very impressive.
Never
Weekend
done.
volunteering in the ER, used to do that every Friday and Saturday night in college, 760.
Wow.
Wow.
That's impressive.
Wow.
Very impressive.
But
That is
we
crazy.
You were alive?
That's a
Were
professional.
they-
yeah. That guy was indicated.
Yeah, that makes sense.
So that kind of brings up a couple of points, is that one of the facilities that I've looked at has this rule that I cannot complete my medical clearance until an alcohol level is below 100. But when people are living at 280, and that's just where they live,
Right.
and they're talking, I don't want them to get to 100, and especially a particular patient. The last time they got to 100 because they waited for the medical clearance, they went to DTs and got admitted to the ICU.
Right, or they'll see.
So 100 is an old law, right?
Yeah.
That I've never been able to find in the books, number one. So when did intoxication change from 100 to 80? Do you know when? It was during the Clinton administration.
Okay.
So when somebody says we have to wait till they're below 100, say, well, that changed during the Clinton administration, right? So that's a long time ago,
Yeah.
right? And that's not proven. I mean, I understand that sometimes that's important for when you want to refer somebody out to be admitted or to get screened. But for us, it's not important. I mean, the process of screening psych patients is totally dependent on where you're working.
Yeah, exactly.
Right? It's got no rhyme or reason. It's totally, you need uric acids and CBCs and all these things.
How about a urine drug screen?
Right, the urine drug screen, right.
Yeah.
So, but in some ERs, you need absolutely nothing, and that's what works out best. If you need a lot of routine tests, then you can do it, or the psychiatrist can do it, right?
And I see this question asked frequently. You get an alcohol level on a patient. Now that you have an alcohol level, and their sobriety time is going to be 5-6 hours, and 2 hours later you deem they're clinically sober, can you discharge them? And my answer is always 100% yes. But people are afraid because now they have a number and calculate it out. It doesn't meet under 100, and I'm like, that's crazy.
Right.
It's all
But
in
people aren't using their
documentation.
clinical skills to assess patients.
Right,
They're
I
just
mean, we
using
know that
numbers.
alcohol, depends on what paper you read, should drop about 30 milligrams of deciliter per hour. Again, depends whose paper you read. We say there are fast decilitors and slow decilitors. A whole bunch of literature show that's not true. So, I generally don't get an alcohol level. I'm sure you guys don't, unless it's somebody
Right.
we don't know.
Right.
And if that person comes in and we don't know them, then I know that their alcohol should drop by X amount per hour. And if they're not waking up according to that amount, then I'm probably getting a head CAT scan on them. But if you work in the ER, I've never seen anybody who's drunk. You're probably gonna get a head CAT scan on that one patient you see a year. And if you work in an ER that has lots of drunk people, you're not, right? And every now and then you're gonna get somebody with a subdural you weren't expecting, right?
Just had that.
And the good news is most subdurals we do nothing about. Right? Well, you just had somebody with who was in the ER for a while.
We had a guy who just came in for bizarre behavior. He was actually taken to another hospital by ambulance, and when he got to the other hospital, they were swamped, so they triaged him to the waiting room, even though his complaint was bizarre behavior attacking family members. So they went to the waiting room, and he decided he didn't want to be there, so he took off running down the street. A different EMS agency picked him up, took him to a different hospital, which is where I happened to be, and he'd never been here before, and he was 100% answering every question appropriately, no focal neurodeficits, but he looked chronically ill. He had 3+ pitting edema, bilateral lower extremities. I have 0 chart or any history. Patient doesn't speak English other than hello and tells me his name, and that's it. So I said, I don't know what's going on with this guy. So we ordered labs and ordered a head CT, and he had an acute on chronic subdural.
Right.
I don't think that was explaining his behavior, but nonetheless, I couldn't just.
Have you guys yet seen your
Awesome.
first guy with a big subdural who looked perfect
Oh, yeah.
with normal mental status, and they had a big subdural? You go, it has to be the wrong patient. And you go, that guy's a big subdural, and he's like, his mental status is perfect, right? Yeah.
Yeah.
So, but that's, I mean, stuff like that happens.
Yeah,
If
it
the person
happens.
comes, but and with belly pain for the 3rd visit, give me a good reason not to CAT scan their belly for the 3rd visit for abdominal pain, right?
Yeah.
I'm not some hero. I'm just the guy who's not an idiot that I'm going to send the guy out after 3 ER visits for belly pain, right?
Yeah, we actually just had a similar patient. I don't know if I talked to you about it yet, but nonetheless, it was a patient that I had seen with one of the other docs. Had been seen by the other doc previously, a few weeks earlier, for epigastric pain. It was a somewhat elderly female, 60s, I want to say late 60s. Epigastric pain had been going on for 3 weeks. History of stents 15 years ago. Continues to smoke, and had a troponin of, I think, 2 initially. It was an NSTEMI, got admitted. Stent was occluded. She complained of epigastric pain still after the stent. Cardiologist said, you'll be fine. The stent needs to be open for a little bit, your pain will go away. Comes back to see me 2.5 weeks later with the same epigastric pain, says, hey, my doctor lied, it never got better, and CT'd her belly that had never happened ever after her pain never went away, and she had a huge pancreatic head mass with mets to the liver with
Right.
a malignant pleural effusion.
And everybody says you're the brilliant Dr. Torres, which may be true.
They were stunned. Yeah,
But,
they were,
but you're the person who says this is somebody old who had, how old is this person?
she was in her late 60s, early 70s.
Somebody says this is somebody who's in their late 60s with belly pain. It's, you know, only an idiot would not do a CAT scan.
Yeah, it was appropriately taken care of initially, and everyone said, yeah, it's epigastric pain, no history other than cardiac stents, and she had an elevated troponin with an abnormal EKG, and appropriately was admitted and treated. And even after the appropriate intervention, she still complained, and I think that's where it was missed, and that's what she was upset about. She goes, everyone here has been so nice. Nobody listens to me when I actually am in the hospital. I said, I can help you now. And and then when I told her that she's going to have to stay in the hospital again, she was wanting me to transfer her to a different state. And it got really chaotic from there.
Right.
But nonetheless, she wanted me to transfer to Maryland, which didn't happen.
Your future home state.
Yeah.
All right, so let's do the articles. Which one's first?
We're talking about naloxone, so.
You want to do naloxone? Just got naloxone.
Yeah. I got that one.
So this actually was I don't know, I'm on the fence on this article. I mean, they kind of bash how we do things here.
Anybody want to run a chair?
I offer them mine.
If there's 7,000 people out there, can anybody send a chair over? For
I'm good. I've been just sitting for the past hour
Just
drive up here. Heard about the Maryland
All right. This is a I'm stunned, Doug.
I'm not.
This is a pharmacokinetic properties of intranasal and injectable formulations of naloxone for community use and systemic review. So this is a literature review of how Narcan's available to the lay public and what's out there. So the FDA currently has approved 2 naloxone products to use by lay persons in the community settings for emergency treatment of suspected overdose, and that's the concentrated sprays, either a 2 milligram or 4 milligram auto injector that goes in a nose, or an intramuscular auto injector.
So
I think we've looked at both of them in the
That's
past.
the Adapt
Vizio
ones, right?
and the Adapt.
And the Edzio.
Yeah,
And we wrote
Vizio.
a paper. No, but I read that with you, right?
Yeah.
So we wrote a paper on the Edzio that's online when it first came out.
Yeah, so it's like an EpiPen.
And the Edzio,
auto injector.
really interesting product. It's one of those things that like it'll talk to you. It'll
Yeah.
help your family. Like it says, you know, inject now, blah 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 blah. But if I remember right, it's very expensive.
Yes. Yes. So any of the auto injectors are, that's prefab. I mean, we
Yeah.
went through the EpiPen debate for years, and this Narcan injector is just as bad. But on this here, it calls us our, what is it? What was the word it used for the way we give it? Unapproved
Yeah.
Narcan preparations, and it kind of bashes the way we do it here in Jersey with the pre-filled syringe, saying how the intravenous preparations are never intended for intranasal use, and
Yeah.
they went into statistics about how 60% of people, you know, who are trained on it still can't do it that way, and
Yeah.
we have great success with it here in Jersey.
Yeah, there was some article. Was that the one of 43 subjects or something, where they
Right.
where they all got it wrong, right? They had
Yeah.
0% success rate.
Right.
Right.
It was very.
How could that be? That didn't make any sense to me.
I don't know. I think the way we did it here in Jersey was well. I mean, we had a mandatory Narcan in service and
Right.
to all the EMTs, taught the class for an hour or two, and then it had a skill lab associated with it. And I think we've seen the benefit all over the state, how it's been effective and useful.
It was a nice review. I did think it was kind of biased. They really did bash
Yeah.
the way a lot of people give naloxone.
Yeah, absolutely.
What was their recommendation? Just all IV?
No, to buy the commercially available, super concentrated 4 milligram.
Who paid for this stuff?
Well, we're getting to that part. So that was the
No,
most
I mean,
interesting part of this
The last
article.
part of this, if you skip to the end of this, it says it was sponsored by Adapt Pharma Incorporated, Pennsylvania,
Right.
USA.
Although I haven't seen any recent reviews on the pharmacokinetics of naloxone and a review of the literature. So that's why I like the study.
Yes.
But I did think it was very out there in terms of how biased it was.
Yes.
Right? I mean, the authors were just very much bad-mouthing it.
Yes.
But the pharmacokinetics were kind of interesting to me, like how IV, intranasal. You want to talk about that? Some of the
Yeah,
tables?
I mean, as long as you get by the first pass metabolism. So Narcan doesn't work if you swallow it. That's why there isn't a very well Narcan like pill for this, you know, that you can take, because the first pass metabolism through the GI tract and the liver just destroys the Narcan. So you have to get it in one way or another. And that's why it's so nice using the intranasal thing, because it's directly absorbed through the nasal mucosa, as well as the intramuscular injector for the auto injector for the layperson, or the IV preparations. As long as it gets into the bloodstream without going through that first pass metabolism, it seems like it's very effective in reversing opioid overdoses. And I think that's what this paper stresses. I mean, some of the tables, if we looked at, it looks like figure 3 with the mean naloxone plasma concentration versus time curves. I mean, I think that illustrates it the best through this, if we're going to skip ahead to that. And if you go right down the middle of it, the upside down triangle is that 4 milligram intranasal, one spray of the concentrated 4 milligram, runs right across. It's pretty steady. The high, and it first order connects there, I guess, so it's twice as high for the 8 milligram injection. And then the lowest is the 0.4 IM, but again, they all reverse.
Yeah, I mean, I looked at that table, and the first time I read this article twice because I liked it so much, and I thought that, does this mean we should all be giving 8 milligrams, not 2 or 4? Because the area under the curve,
So much greater, yeah.
Yeah.
Yeah, I mean, even with the square boxes, the 4 milligram intranasal, and this is, it's really simple. Has anybody used the Adapt? I mean, it's you put it on there, you just click it, and it's such a small volume with 4 milligrams of Narcan.
So I think if I remember, it's like 0.1 ml.
Yeah, it's
So
such
it's
a
a low
small
volume, high concentration.
And I think that's what the author's getting to as the key to intranasal preparations working. Is using the high concentration, low volume, because it says a lot of it is in the 2 milligram per 2 ml preparation that we use. He cites some of the stuff that caused the problems. It runs down the back of the throat, it's swallowed versus absorbed, and the first pass metabolism, you just lose the volume.
But it'll last longer and work quicker if you give 8 milligrams versus 4.
Yeah.
So does this article tell us that we should all be giving 8 of intranasal naloxone? I mean, maybe the police have it right.
Yeah, I mean,
not because they've read the literature, but
it's also illustrated in figure 4 the same way. The
But
upside
their
down-
preparation for intranasal is still the lower concentration. I think they're saying that we should put,
It's high concentration, low volume.
yes, that's what they're saying, probably
Right.
put that in the nose.
Yeah.
Or in your.
But when they looked at
400
that,
ml.
this is the Adept. I mean, right? That's what it is. It's 8 milligrams, 2 sprays of 4 milligrams per 0.1 ml, and that lasted the longest and worked the quickest. Right?
I mean, not to be biased or to sponsor or shout out a product, but that's what I carry in my TAC vest, is the Adapt.
Right. But it's not essentially free.
No, it's expensive.
It's $136 cash
Yeah.
versus $20 for our regular orange box.
Right. I mean, do you fundamentally believe that there's any real difference? I mean, what if you gave 8 milligrams of
But that's the whole thing. If you give nothing and just resuscitate your patient, it doesn't matter. If you fix the hypercarbia and hypoxia and control the airway, you don't need Narcan.
Yeah, but maybe you're fixing it by bagging them, and now you've opened up the lower esophageal sphincter, decreased blood flow to the myocardium. You're causing them to aspirate.
Or
You're causing like a pneumonitis.
Or you CPAP them.
Right.
And you don't
You're
gotta let
CPAPing them, but
As long as they have
then they still could
spontaneous
throw up, and and you're CPAPing them, but unfortunately, even though you're CPAPing them, but many people are still going to grab that bag of death and start squeezing it. And to me, this is why I tell when people say just bag them, I go no, don't just bag them because you're bagging wrong. Number one, the answer should be just wake them up, right? And just give them naloxone. Don't bag them.
I think the answer is resuscitate them, because just giving them Narcan and waiting, they'd still get messed up. And then if you just bag them, they get messed
Right.
up.
So
I
this is
think
why
we
we're
have
so
to do
successful with naloxone when police give it to just anybody lying there, because odds are they're going to have the heroin overdose, right? We're lucky. We're not good.
Yes. Yes.
So I think one thing that was interesting in this article is they kind of focused on the use of naloxone for community use. So take home or prescription naloxone for family members potentially of overdoses. So in terms of that and in terms of ease of use, it sounds like this might be a better option for them if we still can't figure out how to get it right with the MADs in the
And I
community.
prescribed the Narcan to myself, went to the pharmacy and picked it up, and it was $25.
But which one?
The
This one?
Adapt, the 4 milligram per 0.1.
With insurance
With
coverage?
With insurance.
Oh, so with insurance.
So
Now you're on the hit list.
Right.
Now you're on the PMP.
I think for house and home use, I think it's really important that they get that
Yeah.
8
Mhm.
and then
Kids, like
I
an
would think
EpiPen.
so.
Everybody
and
gets
then
two kids.
avoid any
Yeah.
EMS exposure. You know, you've solved the problem,
Right.
and then because for an EMS exposure, dealing with a combative, withdrawing opiate patient, you know, that you've just given 410 instead of 0.4, just enough to bring the respirations out. But
Right,
it's
because the
always-
treatment of heroin pre-hospital is completely different than treatment of heroin in the ER. And maybe in the ER, it's important just to, you know, let them wake up slowly.
Right.
In the pre-hospital setting,
That's why I said,
we don't
let
have that
the
luxury.
family, you let the family give it and reverse it, but, you know, unfortunately, you can't bring that to the BLS standpoint, just enough to get their respirations up, because you can't titrate it.
Right.
As EMS fellows and paramedics, I always try to titrate.
Yeah.
You know, just titrate, you just go up by 0.2 if you want.
When you have IV access, it's
When you have
very
IV,
simple.
Yeah.
it's just nice and easy, and then you're not fighting with them, because you're calling in for ketamine and whatnot.
Right. But I mean, although you have mixed ingestions and scopolamine, all this stuff, how many people really fight after giving naloxone?
We have a lot.
I
Or
mean,
refuse. Again,
I wouldn't say it's the majority, though, right? It may be a lot, because we all tend to remember those people, but more people than not wake up slowly, don't they?
it
I mean,
depends.
they wake up fast, but they're not fighting you when they wake up. I would say,
Actually, a lot of people have almost like an emergence reaction. When they come out of it,
Yeah.
they're like totally reversed. They're like, what are you guys doing here?
Tachycardia.
Get out of my
Right.
house.
Yeah.
They're diaphoretic, they're freaking out. They're like, and now, you know, that's why, you know, it's putting the patient through some undue duress, because now you just reversed everything.
so you want EMS to wake them up slowly?
I would think that EMS should bring them up just to where their respirations are. In New Jersey, of course, everybody has to go to the hospital. So they're gonna be going to the hospital one way or another.
I mean, bringing them up slowly to just help with their respiration is a very ER way of thinking,
Yeah.
right? Pre-hospital, we said, you know, listen, maybe sometimes in pre-hospital setting, we should give the, 4-8 milligrams, because they're going to wake up in probably RMA.
True, except they wake up and they're all upset. It would be nice to RMA. Now, how about this? Can you take an RMA from an intoxicated person?
Right. I mean, this
If
was
they're
our.
reversed in AMO times 4, I will absolutely.
I mean,
do
this
it.
is our-
How long is that Narcan going to last for?
I mean, this is our clinical
As
pearl.
opposed to what the.
Well, based on your recent study, actually, it's not
Right.
bad.
No, because they all go to hospital.
Right.
They
I
all
mean,
went to hospital.
Jim, you want to talk about the half-life, because they spend a lot of time in the article talking about half-lives and
90 minutes, right?
what?
It was like 90 minutes.
Yeah, I mean,
90
one
minutes?
paper showed up to 90 minutes.
So that's the 8 milligrams.
Different half-lives, right? With different amounts, but one paper showed up to 90 minutes.
Yeah,
We-
but the drug itself is also wearing off, so.
It's wearing off, so the heroin could
Right.
last longer. But of course, we do know from the RMA studies that
But the heroin
if you're
wears
alert
off,
or
too.
times 3, then or times 4, then you really never need a second dose in the study, right?
Correct.
That's true.
But you release them, they go and they do a couple more.
I mean, the important thing is,
Right.
I see the point the police want them to go to the hospital, because when you go to the hospital, that opens the gateway to rehab care and further continuity of care. At home, they don't get that. They won't see the Narcan counselor. They're not part of the grant. They won't have the financing. But again, if they're not ready to stop or they're not ready to fix a problem, it doesn't matter how much money or grant time you put into it, they're not going to stop. So going to the hospital is just really, when a patient doesn't need to be there, is an ER burden for the ER.
Right, and we've discussed this so much. You know, if they show up in the ER and they're out in the waiting room and they do not want to come in, and you're busy doing something, and the nurse says there's a patient in the waiting room who's alert or in times 3 and does not want to be seen, what are you going to say? I mean, maybe you might say, well, have them wait a second till I can get there. But if you're really busy, you can't do that. And then you'll say, okay, I'm not going to stop them from walking out. Will you stop? I mean, do you stop them from walking out before you can examine them?
Not at all.
No.
So security comes to say to you, Doc, if you want me to stop them, I will till you can get here. What are you going to say?
Let them go. People have a right to make their own decisions.
Yeah, this is America.
As long as you can tell me that you're A and O
Land
times
of
4,
decisions.
as long as I can definitively state that, then yes.
Right. But if you don't see the patient, you can't definitively state that.
Sure. And I've done
maybe-
that. I've done that many times where nurses have told me, like, you know what, the patient doesn't want to be seen. I'll quickly run up to them and make sure that they're ANO times 4, and I say you can leave.
So now you're single coverage. You're really busy in the main ER, and security says, "Should I hold a guy until you have time?"
So it's a trust issue, or who's telling you that?
He's pretty calm. He's kind of just barely awake, breathing. He's doing fine. And then as soon as we got him in the BLS truck, they were pulling away and they stopped. And he just went just insane. And they were like, oh, we need to sedate him. And the guy was just like, you guys can't trap me. And it was kind of similar, like Tagore had mentioned. It's like, he knows exactly what's going on. It's not his first time being Narcan.
Right.
So EMS was asking me, like, what do we do? And I was like, I mean, at this point, we were actually ALS. We were leaving.
Yeah.
We had been released. Essentially, we've been.
I mean, the answer is you make a decision,
Yeah.
you know, to either sedate the guy or release him, and then you stick with it,
Yep.
right?
Yeah.
Because there's some point where you try and rationalize with a patient over and over and over again, and you just go, I'm getting nowhere, right? And I'm just not sure this patient's really alert and oriented times 3. I don't know the patient. There's no family members around, so I'm going to just stick, you know, go with the decision and follow through with it, right?
I mean, I think, all the cases that have gone about with this always sides with the providers, the doctors, the NPs who say, like, I am concerned that, you have a head injury and you're not in your right mind. You're making a clinical decision. It's not that you're holding them against their will. They're literally like, you don't understand what's going on.
And I do think, I mean, I've had this situation several times. There's something to be said to siding with the family. The family says, I know he looks good and he's making sense and he doesn't want to go to the hospital, but this is not who he normally is. And you can document that, and then you're supporting the family decision. And now I feel much better about taking somebody's rights away from them if the family says this is not how he normally acts.
Sure, because you're erring on the side of patient benefit as opposed to negligence.
Right.
That's always easier to defend.
All right, anything else with the article, Jim?
I think it's pretty straightforward. I mean, yeah.
Any other thoughts about this article?
I think the take-home message is pre-hospitally when we have limited resources. It's the concentrated, high-dose concentrated. I think the 4 milligram is going to be my clinical practice to prescribe to my squads. And in the ER, it's going to be more of a titrated Narcan to effect intravenously or nebulized if I'm not putting an IV in. And the nebulized Narcan is easy because it's self-regulated. It comes off when they don't want
Right.
it anymore.
I do have one thing to say about the study is, especially with the figures, you have less than 30 sample size for like every single study. So normal distribution barely applies. And I'm kind of curious if they reported the median for all of these doses, if it would probably not show as much of an effect.
That's interesting.
Because that's what I'm seeing right here. Because we have low sample size. So I feel like if I got this data set, it would all be lower if I was to graph it with a median.
So maybe they fooled us.
And you have volunteer bias
Right.
in the study.
Of course.
Because everything was volunteered. So,
They're all healthy.
yeah.
Right.
If you do the wrong test.
So, I don't know.
That is interesting.
I would kind of like want to look at the data set.
Well, if you guys are out there, if you're willing to share your data set with us, please send it. We will analyze it and send it quickly back to you. Although they have no benefit of doing that. So you're going to do 4 milligrams. But the 8 will last longer and work quicker.
And it should be like an EpiPen, you get 2 of them when you go, or you get, families should get 2 of them, or the squad should have 2 of them on the truck.
So every time you see somebody, so if you're with a patient pre-hospitally who's going to RMA, and they say, can you give me a prescription for my family member, will you do it?
I'd write it right for the person on the spot.
Absolutely.
And then what if that person says, can you give me one for my brother too?
Sure.
I mean, you can buy them over the counter in Walmart, right?
Yeah.
You don't need a
Some
prescription.
states you don't need
It depends where,
Yeah.
not all places.
I didn't think, is that true in New Jersey? There are other states, but you buy it in New Jersey? Oh, you can, right? Yeah, you
But
can buy
it's one of those.
more.
It's one of those gray area meds that the pharmacist can dispense.
Yeah. And then there's a lot of public health fairs where they just give them out.
Dispense.
Right, there's many fairs out there where the police are just giving them out at the fair. You can just go pick it up.
Yeah.
Right.
Yeah.
All right, what's next article?
2 trauma articles, right?
Yeah, so we had the golden hour.
The golden hour. So we're going to do at some point this year, do a whole journal club on this magical golden hour.
It's dead.
That's from my place.
So this is a couple of famous people who work in emergency departments who wrote this. And this is one of the golden oldies. I mean, although it's not that old. But who's doing this?
I can.
Okay.
So basically, this was it was a secondary analysis of multiple different facilities across the United States from 2005 2007, where they looked at trauma transports to the hospital with criteria being the patient had to be an adult over 15. And they had to have certain vital sign abnormalities met: a systolic blood pressure less than 90, a respiratory rate less than 10 or greater than 29, and they had to have an altered GCS of less than or equal to 12, or they had some sort of advanced airway intervention in the field, and those were like their inclusion criteria. And they looked at response times, like activation time, response time, on-scene time, transport time, and total time. And we're looking at whether or not shortening that time made any sort of difference in the outcome, which was in hospital mortality. And I mean, you can sum up the entire article by saying no, it didn't make any difference. I mean, no matter which way they broke it down, whether they were just looking at the activation time or the response time or the transport time from the scene to the hospital, if the paramedic team either sped up or slowed down even by a few minutes on either end, it did not make any sort of significant measurable difference in the end result of the patient's mortality. So, I mean, really what there is to glean from the article, in my opinion, is while lights and sirens are great, don't sacrifice the safety of your crew members and the patient en route to try and get there 30 seconds or a minute faster, because in the end it doesn't ultimately make.
Yeah, I mean, we always separate that discussion with lights and siren to be your response versus going to the hospital. And we know from 2 of our studies where we had medical students drive the same exact route, same time of day, same day of week, without the lights and siren from the location to the hospital, that it changed absolutely nothing, right? And we did another study which looked at life-saving interventions, and nothing changed for anybody basically if you put in the lights and siren. And there's a whole bunch of websites out there where people will testify against you for teen lights and siren use. Unfortunately, but nonetheless, that's the reality. So if you want to put on lights and siren, just gotta give me a good reason. Like, there's all this traffic, the patient's sick, and there's some potential procedure that the ER is going to have, or some knowledge base the ER is going to have. So I'm stuck in traffic, and I want to get to the hospital because the patient's doing worse. All right. But I mean, I'm the first person, like at night or if the roads are not busy, to drive to a scene and never put the lights and siren on in my car, right? Like, all I'm doing is causing a traffic hazard. And before I cross a big intersection, I'm the first person to shut off my lights and siren, because I realize everybody's going to change their driving around me because their lights and siren. Or what'll happen is they'll see you in the rearview mirror, they'll think you're a police officer, and all of a sudden they'll hit the brake and they'll be in the fast lane. And were you going to help somebody enough that it was worth doing that, right? Because people all freak out and they stop in the fast lane. So, AJ, what do you think?
My main input is basically just that the result they found is probably true, mainly because they're testing it in other directions and they couldn't find anything. For example, they used multiple imputation with Bayes' theorem to fill in all their missing data and still found nothing. And that was just like, there's probably nothing. Then if you're doing that, you're still not finding a direction with your analysis.
So we can say that. So what's our take-home message here? The golden hour is something completely made up, or there's just no benefit to. That we just do that to emphasize that trauma patients should get definitive care as soon as possible.
Yeah, I think it mentioned it in one of the limitations in this article is that I think a couple things to think about is that the golden hour came about in 1975. Before the EMS system has matured. The EMS now compared to 1975, I'm sure, is drastically different. And then on top of that, most patients of the total EMS time was well under 60 minutes. I think it was 36 minutes. I think it was the average total EMS time. So EMS is still, on average, getting patients to a hospital within 60 minutes. So I think the golden hour is kind of irrelevant at this point, because we're already doing the appropriate care by getting these patients there fast.
We know in certain cities like New York City that trauma's a BLS call, right? So there is no ALS unless there's an airway issue or something, but it's a BLS call. I'm not sure I agree with that for outside of urban areas, right? If you're passing an ALS unit en route to a hospital, have a paramedic unit. They bring more knowledge. They can decompress chest. They can intubate appropriately. But if you're in an inner city where it's going to be a clear delay to get to a trauma center, then I don't see any benefit.
Or meet en route as well.
Right, a line of sight.
What I thought that was interesting is how this article, part of the cohort was everything from urban, suburban, rural, from all over the U.S., Canada, and it kind of lumped everyone together. But I mean, I agree. I think that if you have a lot of trauma centers all within 15 minutes of each other, that's great. I mean, South Florida, I mean, Ariana can attest to this. I mean, South Florida between Miami, Fort Lauderdale, and kind of North Broward County, you have probably, 4 trauma centers within 15 minutes, 20 minutes of each other?
Every hospital is now a trauma center.
Yeah, so I
Literally
mean,
every hospital is a trauma
you
center
could
now.
pretty much stand on the roof of one and see the other.
Yeah.
So it's kind of crazy, I think, in those settings. But Western Broward County, there's no trauma center, so now everything has to get taken out east because everything is lines the east coast of Florida. So it was interesting growing up in Western Broward County how that was something that came up, and it was like, oh, we need to fly traumas 15 minutes down the road, and it's like it's a 20-minute drive and a
Right.
30-minute helicopter ride.
And this is Philadelphia's 2 papers where people did better when they were brought in by police over EMS,
Yeah,
right?
exactly.
That everybody refers to. So better outcome when police bring you in than any EMS at all. I mean, Janae, when you trained, who brought in traumas? Was it BLS, police, or ALS?
So it was ALS, and you oftentimes would tier with BLS if it was an outlying service where it was a little bit more rural.
And this was in Chicago?
Iowa, for
Iowa.
my paramedic stuff.
But what about residency?
Oh, I'm sorry. So it is ALS. So the fire would go first, and then ALS would meet them there. They didn't have any just BLS services in the inner city area, anyways.
And fire couldn't transport.
Right, they could not.
Right. So, I don't know. Are we okay with BLS transporting traumas? I still hate when people get to trauma centers and somebody says, oh, why didn't you put an IV in? And it's like, why? I mean, we did that SID study, second IV in trauma study, if anybody ever read that, where we showed that it's a complete myth you need a second IV in trauma, right? You don't give more fluids. It doesn't
Right.
change outcome whatsoever. And we called it the SID study, second IV in trauma study. No benefit to putting 2 large bore IVs in trauma. But it's the more ATLS dogma, right? Give fluids. And when Ken Maddox's study was years ago now, to say if there are at least 90, just leave them the freak alone, right?
I think it's really just screening, because the sooner you get a sick trauma patient to definitive care, that's what it is. But if they're triaged well and screened well by a medical professional, if they take 45 minutes to get to the hospital, or they sit in the ER bay for 45 minutes, what's the difference? As long as they're screened, if they're acute or not acute, you know? If they're ill and they need surgery, they need an XLAP, they need a hole drilled in their head, that's the person that you want to get to the hospital as soon as possible. Stop the bleeding, do the XLAP, do what you have to do. But if the guy's got a gunshot wound through his shoulder and the bleeding controlled, does it matter if that guy gets in the hospital in 45 minutes or
Yeah, I see what you're saying, but we teach this so
Just need
poorly to
somebody
EMS
to
personnel,
screen them.
right? If we got a bunch of really smart EMS personnel together and we said, who needs to go to the OR from trauma automatically, they would not know, right?
And it's better to get them to someone who can make that evaluation.
But why don't we teach that a little bit in why don't we teach that if you have a GSW to the abdomen, still in 2018 the standard is to go to the OR for an XLAP. Well, why don't we teach that? Why don't we teach how usually we're going to CAT scan and we're doing embolizations to people in IR? Why don't we teach that in so people have a better idea of to move? I still don't think we get off the scene quick enough with trauma.
No.
I still think we sit there. This come up in Journal Club over and over again when people say traumatic arrest. Oh, it's still stay and play. No,
they don't.
right? But smart people think this, and I don't understand why.
But dead trauma patient, that's an easy treatment.
And every time
Unstable and they're
every time we bring up doing needle decompressions or finger thoracostomies, people go, "Really?" I'm like,
Well,
"Yeah."
and they're-
Why did you intubate and you didn't decompress the chest?
Yeah.
Right? How does that make any sense in trauma?
The biggest thing is any benefit that you would have to get them to the trauma center quickly, you lose when you think, oh, should I go? Should I stay? Should I do this first and then go? You lose all the benefit by thinking about it too much.
Right.
And
But
then
I
there
don't
was
think
also
paramedics
that-
know what's. I mean, I think it's an injustice that we don't have paramedics rotate in the ER after they become paramedics,
Yeah.
because now they're smart enough to know the right questions to ask.
Exactly.
It's just like when you're a medical student, you're not smart enough to know the right questions to ask. Now, wouldn't it be fun to rotate through some of these departments? Because now like what the right questions to ask people.
Sure.
And it makes you the next level medic too.
Yeah.
Transition.
Because you're given an entry skill set. I truly believe a paramedic needs 5 years in service time to be able to hold their own. because they're taught to the minimum standard and release them to the wild. With that wild time, they got 5 years to grow and learn and to be a solid medic. You know, it takes time. You know, you're trained to the minimal set of standards, and that's why I think medics working in the ER is an absolute must for the future
Right.
of EMS.
But I'm sure, like me, you just think, let me just sit down and tell you what's important, buddy.
Yeah.
Right? And I can do that like in 45 minutes or less, right? But instead, we
As long
spend.
as they have the background knowledge to hang with you.
Right, right.
And that's what they get from medic school to take that next level leap.
But I also believe that there's a big problem in paramedic education that there aren't enough EMS physicians at class
Totally.
teaching them. Now, part of this is us, right? Because it's hard to get to all these classes. But, you know, we're not there, right? So you're learning from people who are potentially making the same mistakes you are, right? Unless they have a good knowledge base. But there needs to be some EMS physicians there to say, let me tell you how it really is. I've been doing this for a while. I was a paramedic. I was an EMT. This is like what's really important, right? Right?
100% agree with that. I didn't know my.
And I see this all the time. I see that, you know, I was talking to somebody yesterday about, you know, belly pain in a kid, blah, 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 it's deception. The paramedics, I never heard of that. And I'm thinking, but this is what you worry about every night in a peds ER with kids with abdominal pain, you know? And why is it that's not in the books? I have no idea. You know, why is it that IR is not mentioned in the paramedic textbooks, you know, about, you know, doing embolizations of people who are bleeding? I just had a very smart paramedic say every time I bring a trauma to this trauma center, they go right to the OR. I said, they're all going right to CAT scan. He goes, not my patients. I'm like, no, you're wrong. You're a really smart paramedic, but they're not going to the OR, right? And how often do people go to the OR for that much at all anymore, right? Right, years ago, everybody would get every trauma surgeon would do 1 million splenectomies. Now they, you know, now it's almost never, right?
I think it's super important for them, for the ER providers to know that there's an EMS world and to experience it a little bit as well,
Yeah,
and
definitely.
vice versa. It's a continuum. It's all a continuum. And by you bringing this kid who has this condition that needs a PICU to a non-PICU place, you don't understand that you're actually harming them, because now setting up a transport is complicated and long. And if you had just driven 25 more minutes, they would have been better off.
Right.
And you wouldn't know that unless you spend some time in the ER. Same thing with the trauma. You know,
Right.
you gotta kind of know what's happening. I can't even tell you the number of times I've flabbergasted a BLS crew when we say, no, bring this person that you just raced here, lights and sirens through, caused 4 or 5 car wrecks, ripped him out of the stretcher, and now we'll go put him in the waiting room. And they're
Right.
like, wait, what?
Right.
They don't even.
And when they complain about that, we go, no, we were that BLS person too,
Right,
and
right.
we were pissed off
Exactly.
too when we raced here and got here, and you
just
said go to the waiting
have
room
to
because nothing's
understand
wrong with you.
The next, what happens
Right.
when you get here.
Right, right.
I just pulled the ambulance up to the waiting room.
This is why it's easy for us sometimes to pronounce traumatic arrest at the scene, right? And people say, how do you do that? And you go, because I know what's ahead, right? I know what step 2 through 10 is, and none of those steps are good for this patient who's a blunt traumatic arrest on the ground. I know they're not they're not walking out of hospital alive, and so it's easier for me to do this, right? Because then even if you get back a pulse, that's not something to be happy about, because you're going to go to the ICU for a month to get a $10 million bill, and the chance of survival is 100%. Chance of death is 100%, right?
So do you think that as time goes on then, like obviously as a new EMS physician, that decision I feel like is maybe a little bit harder for me than some people who are a little bit more seasoned, because I actually think one of my attendings where I did residency said this to me, that one of the hardest things they had to learn was when to call a code on a relatively young person.
Yeah.
So like when Vita just last week had a blunt traumatic MDC arrest, and we were only 10 minutes from a trauma center, and it was a relatively young person, and I didn't feel comfortable calling it. I think it was more, not because I thought that they were going to have some sort of excellent neurological outcome, but I think because there was just a part of me that still had that maybe ignorant or naive hope that
Yeah.
there was something I could
we
do
were all
for them.
there.
I mean, I think it's something that experience gives you, because you see all the next steps. I also think, young pediatric cardiac arrests are different, but if you see them over and over again, you realize, well, I brought them to the ER, now they gave epinephrine and they worked the patient for an hour. And they go, but I gave the same epinephrine, right? And I did the same exact stuff that they did, but you have the advantage of knowing what's going to happen in the ER, right? So to you, maybe that is easier. Certainly, I think the decisions will become easier in the short run in older people, right?
Mm-hmm.
Because now you'll have somebody pre-hospitally who's 80 years old in a blunt traumatic arrest, and somebody will say, but that person was just talking, and put them on monitor, and they're asystole, and you go, they're not walking out of the hospital pronounced, right?
Right.
So those decisions will become easier with older people, and you won't even, think twice about it because you know everything ahead. But young people, we always, we always do that. Plus, leaving a kid at a senior at MVC is always is very challenging too.
I mean, but this was like.
Plus, there's a whole separate argument about organs, right? So,
Sure.
Yeah.
what about organ procurement for
Right.
people? But in a multi-system trauma, you're just not going to get organs, and you could get tissue up to 24 hours, and you could do that, after they go to the morgue, right? That doesn't have to happen, in the next hour.
And I think also, depending on the circumstances, if you just don't feel comfortable pronouncing the field, then don't. I
Right.
mean, there's not a mandate, and especially like if somebody falls off the top rung at a stadium and you got 15,000 people staring at you,
No, Charles,
and you're
don't.
working
Yeah.
them,
Yeah.
you better work them right to the ambulance and on your way over.
Right.
Well, on the
And
way over
these
there.
are
I mean,
situations where-
TRE as
I got
well.
called about a guy who was a fall at a construction site who, was a blunt traumatic arrest. And I'm like, just freaking work the guy, because you have 50 people all staring at you. You get there, and you have nowhere to go. There's, carrying this, it's just going to be such a challenge. Just, decompress the guy's chest, do stuff en route, because all these people are not going away, right? And
And that last image of you working on them as they're going away will also help them. It's not going to do anything with the
Right.
patient.
It's healing, right? And
Right.
really, we're not working
Yeah.
the patient for the patient. They're dead, but you're helping the family, the friend who feels guilty that,
Yeah.
I shouldn't have left the railing down, and that's why you fell.
Right.
It's a
Right.
healing thing. That's that EMS continuum that you probably don't see that side because you guys don't often talk to the families.
Right. It's like when EMS gets there and they say, can we pronounce? And the answer is, I mean, if everything is okay at the house and the family's supportive of this, yeah, absolutely. We pronounce 65% of people in pre-hospital in New Jersey, a bit much higher than most
I mean,
states.
I've gone to a house in the basement with like a 98-year-old woman who was just clearly dead, but there had 5 police officers and there were about 50 family members
Right.
in between us and the door, and I'm like, we're taking this to the hospital
Right.
Yeah.
because we're not pronouncing and leaving.
I guess
And the cops were very happy about that because they
Right.
did not feel comfortable being in that apartment.
A
Sure.
lot of this is going to be time
Yeah.
and your exposure to seeing this over and over again. The more traumas you see, the more trauma resuscitations you do, and the more traumatic arrests you do, the more comfortable you are going to be in pronouncing those patients. And a lot of it, it does have a decision-making tree of, do I transport this patient because of the scene or the environment that I'm in, and you want to just pull yourself out of there. But then certainly you could always, what we do TREs, or termination resuscitative efforts, and you can always do that on the way to the ER. So, certainly this question was raised recently, and my answer to that was, if you have a short transit time, your transit time is 6 minutes. What difference does it make if you TRE versus continue the resuscitation?
Right.
If your transit time is half an hour, definitely there needs to be a discussion. Now, my thoughts are always in blunt cardiac arrest, traumatic arrests, is what's the chance of survival? It's
Right.
damn near none, right? So what do you do with that patient?
Right. And we discussed
and
this
I
during
think-
orientation too, that,
Right.
if the police are on the scene, which they usually are, you, depending upon what town, you go up to the officer with a white shirt, who's a most senior officer, and say, listen, I'm thinking about pronouncing this person. Is that okay with you? And if the guy says yes, then that's great. And if the person says absolutely not, then you say, okay. You have that, you open up a dialogue, right?
Right.
And you have to find the, because the police officers who are not the supervisors are not going to listen to anybody except for their supervisor.
Right.
So you got to take the person with the highest rank on scene and just have the discussion with them. And then you can resolve all these problems usually.
And the biggest thing you want to do is clear the box. And what we have, which is great, is point-of-care ultrasound. Look at the heart. If the heart has no squeeze and the heart's doing nothing in a traumatic arrest, we're done.
Yeah.
There's no futility. And another thing that I am always...
And I would say in a penetrating arrest, especially when nobody's talking to, the heart's not doing anything, you're done
You're
too.
done too.
Right.
And
But you want to do finger thoracostomies on some of those people.
Absolutely.
I think it's, it's a 1 in a million chance.
Yeah. Clear the box. Just clear it and you're done. But the one thing I will always say this, and I continue to harp on this, and it's never going to change, we keep giving epinephrine in traumatic arrests. And there's no benefit in giving epinephrine in traumatic arrests. This is a hemorrhagic shock that's led to an arrest. This is not a cardiac issue that's led to the arrest. Epinephrine is going to do nothing. And to see people continuously now in all your charts in these traumatic arrests giving epi every 3 minutes, and bicarb and calcium, it's like this one
Right.
played no utility.
I mean, Ron, what do you think? You've pronounced a lot of people on scene, especially as a fellow. I mean, what do you think?
As far as,
You know, I mean, does the decision get easier over time?
oh, I mean, obviously, you will embody an empathy to where you will be able to speak to the family with professionalism, your experience, and you'll be able to explain to them exactly what happened and that there is absolutely no chance. And you'll be able to speak with authority and say there's absolutely no chance of recovery. And that you would just be doing more damage than good. In cases of trauma, we've actually had a lot of these cases, and I've counseled medics that says just drop the epi.
Yeah.
And then traumatic hypotension, drop the epi. You know,
Right.
permissive hypotension and fluids and TXA, just because they were trying to work on a number.
Right.
But yeah, after you do it for a while, the biggest thing is trying to, being able to speak to the family.
I mean, the challenging thing is we're getting there and we have to make a decision in 5 seconds.
Right.
Right? Because the worst thing you can do is stand there and go, let me think about this for a few minutes, right? So you either say, I'm sure, I'm not sure, and that area in between gets easier over time. And if you say twice to yourself, I'm not sure, then just work it and go, right? So it's
Right.
very simple. Just like, have I said this before to myself in the last 10 seconds? If the answer is yes, just work it and go.
Right. And I think it's also beneficial in some circumstances to take these patients into the hospital for the hospital's sake as well, because you have residents, you have trauma fellows, you have these people who are trying to learn in order to potentially save someone who is savable. And you don't always know who that patient is. So if there's any doubt at all in your mind, I feel like it's definitely valuable too.
Right. I mean, life is easier for us. We have to, right, because we have an ultrasound machine, right? So life is easier for us to like figure this out. And I mean, that makes. I mean, you have no squeeze in your trauma. I think if you want to pronounce these people, that's fine. And I mean, I always say to the medics, if just put the leads on the toe, just somewhere. If you can just get somebody stuck under a car, the car collapses. I've had this. We had a case. Well, I mean, here, what would you do? A medic calls you and says, "I already called the console." And the doc didn't give a very good answer. But then I saw the doc was trying to call me at the same time. So it was somebody who, somebody was in some town and somebody was started to shoot at them. So they jumped under the car. And then they found them the next morning with their feet sticking out of the car. So they couldn't get to their chest. And they said, we want to pronounce this person. The doc on the console said, you can't pronounce the patient if you can't get to the patient. So I said, are you sure about the story, right? That was my first question. You sure about the story? And they go, we're sure about the story. Blood is pooling. And I said, okay, let's pronounce the patient. And they couldn't get to the chest. And you know what? They could have been wrong, right? But the worst thing I could have done is not made a decision. What were the medics going to do, right? They couldn't lift the car up for hours, right? And so we made the decision. But I oftentimes say those are the kind of cases where you call us, not a general emergency medicine doctor, because we're used to that. And if I was close, I probably would have responded over. But I wasn't close, and it's all a risk, right? But that's a good scenario. What would you have done in that scenario?
Yeah, and you have to be able to understand the mechanics of what they're saying. And as somebody that's been in the field and done the same sort of thing, you'll be able to recognize why you can't get to the chest, as opposed to just climb underneath there and put the leads on.
Right.
Or just pick up the
climb
truck.
through the blood.
Pick up the truck, or cut a big hole in the bottom of the van, and then you can get to the patient. It's just not practical.
Right. It's the old. And I hate when people do this. It's the old. The guy's violent. I just want to give him something to calm him down.
Yeah.
And somebody says, I can't give you anything until you take the blood pressure. And you're like, oh my God. And I say to Max, I feel your pain when somebody says that to you. They are so wrong, right? They are so wrong. And I would say, just give us a call, right? We'll give you a drug so you can calm the patient down. So maybe you can take the blood pressure, right? And all I envision is a medic getting hit because they were trying so hard to take a blood pressure. It's so silly.
Strangled with their own BP.
Right. Right. All right. It was a good conversation. So do we want to do one more?
Yeah, I think we have one more, right?
Yeah.
Just that, kind of along the same vein, it's an article about accuracy of pre-hospital trauma notifications. So the study was done over the course of 2 years at a level 1 trauma center, and they basically collected data from pre-notification forms on trauma activations and analyzed them to determine whether or not people were under or over activating the trauma system. And ultimately, in the end, they concluded that EMS was frequently inaccurate, whether it was overactivating or underactivating. There was a persistence of inaccurate portrayal of trauma triage out in the field, and they looked at like specifically things that were like missing from the pre-notification form. GCS score was the like number one thing that was missing off a lot of the forms, which I found kind of interesting because I don't know that that is truly gonna, in my opinion, I don't know if that really matters once they get to the hospital, whether you know that their GCS was 12 or 9. But anyways, they also had like the wrong age and some missing vitals, and that led to like a 2.1% overactivation and a 1.7% underactivation. And interestingly, very specific, they mentioned that the most people who were like triaged wrong in terms of trauma notification were male patients resulting from a fall on a weekday between 11 p.m. and 7 a.m. and they ended up being transported by BLS units. So it didn't really say in here whether it was like the ALS unit was on scene and they said that they released to BLS, or whether it was a BLS that showed up first and decided that they didn't need ALS or whatever. But that was what they found was most often mis-triaged or mis-notified pre-hospitally.
So some systems give notification and some systems don't. I never know what's better. I mean, one time I remember I responded on something, and so I called the console because I tried to call the ER, nobody picked up in the ER, and then I called the console, and a resident answered, who ended the conversation by saying, you know, what's your ETA? And this was several years ago, so I was a little more obnoxious, so I said, just tell me what you're going to do differently, and I'll tell you what my ETA is, right? And he said, and the truth is, why does it matter, right? If maybe if you're in an ER which only has one BiPAP machine, and you have to get it ready, that makes a difference. If you're in an ER which has several BiPAP machines, why does it matter? Well, maybe you say if the patient's critical, you have to get a room ready, but if you have resuscitation rooms, they're probably always ready, right? And you're not going to do anything that much different. I get it if the patient's critical, maybe you want to get your resources intact, but if the patient's not critical, why does it matter if the patient has chest pain or shortness of breath, right? I mean, that's what, does it really matter?
Yeah, I mean, like, basically this article, which is, I guess, a fair point from an administrative perspective, commented a lot on overactivation being a problem of wasted resources, and they talked about the difference in this particular facility about they have tier 1, 2, and 3 level trauma activations, and they excluded the level 3s from this study, and like they listed their what is activated when they have a trauma, and it's like this huge group of people. Like they have an EM physician, an attending trauma surgeon, a surgical resident team, who knows so many people are on that, anesthesia attending, trauma program manager, respiratory therapist, radiology technician. They have social services, 2 ED nurses, and security. So whenever a trauma was activated at the hospital, all those people showed up.
Right, and we know that you lengthen throughput time in a hospital that has more trauma activations, right? So it takes longer for patients to be seen in hospitals that have more trauma activations.
All patients in general?
Yeah, all patients in general. So that's been shown.
Definitely.
But we also know that over triage is probably the rule, right? And Penn published a paper several years ago, their trauma center, to show about 25% of people, this was their number, should be over triage, meaning they should get out of the trauma bay with no injuries on CAT scan, no major injuries on CAT scan. Probably that's a half decent number, 25% over triage rate, depends whose paper you believe. But I don't know what the right answer is. I do think that lots of resources to this kind of thing is silly, especially when people are in-house, right? Like,
I think that the activation, one of the places where I did a trauma rotation, we were the only trauma center for 2 hours in any direction. So every trauma, if there was even a question about whether it was trauma, was going to be overactivated. It was going to be overcalled and brought to us. And I mean, we had everyone on the team, like Janae said, we actually shut down. We pretty much pulled especially at night, we would pull the reading resident aside. The radiology resident, they would stop reading every other scan in the hospital, delay dispositions for everything else, and then on top of that, if it's a level 1 activation, now that trauma attending at 3 o'clock in the morning is coming downstairs and we only had 2 surgical residents at night. That was it. So I mean, you're pulling them away from the surgical trauma ICU to do this. So I think there was a lot of things that were being taken away, which, like you said,
CAT scan's done for now.
right. There's a hospital I know of when they have outside deliveries, they have the newborn nursery there. They have the NICU people there. They have OBGYN residents, attendings, and fellows. There's literally, for every outside delivery, 10 people who show up for outside freaking deliveries. I've seen mothers come in with babies in their hands in a wheelchair when 10 people grab them, when 10 people greet them. It's absurd, right? You don't need all these services. On the other hand, some ER docs will say, but it makes me feel good when somebody comes in knowing that all these people are here. But it changes the dynamic of the whole freaking hospital. I think
it takes away from other things that are important too. I work in a place like this. Literally, 10 people would show up for this well-appearing baby who warm them up a little bit, but otherwise they're great. Same thing, trauma. All right, they bump their head, but they're fine looking. And then I got this like really sick septic shock, and I can't find a freaking nurse to get me antibiotics or fluids.
Right.
Everything's locked away in the PICS that I don't have access to. And it's like such an imbalance of what about all these sick medical ER patients, cardiogenic shocks, and I can't get any help. But we have these trauma activations that.
And you start measuring those times, then,
right,
then
yeah.
you become important.
That's
right.
what I
Because
mean.
now we have sepsis alerts, STEMI alerts, trauma alerts.
Stroke.
Stroke alerts.
Right. We chest pain centers. We probably need shortness of breath centers
But
too.
we still don't have GI bleed centers, and we need.
Right. We have protocols. Right. There's an upper GI bleed, a code upper GI bleed coming in. Right. Let's all get here.
Brown.
Right.
But that would never happen.
Code
Who
coach.
could have guessed her?
That's
there?
right.
Right. But hence all the patients who are waiting. And now is there going to be somebody in the waiting room who comes in whose EKG takes 30 minutes instead of 5 minutes who's having a STEMI?
Right.
Right.
I don't know. I mean, we're there. Why do you need everybody else? Right. But I mean, I get what they're trying to do. Sometimes it backfires though.
And it has had a lot of bleed over, so now your low-level traumas are still getting a lot of that activation resources
Right.
and delay. All right, a young kid stabbed, hemorrhaging, we're having a lot of trouble stopping the blood. Oh, all right. But
And this is all the sepsis trials, which we learned from the 3 recent sepsis studies, that you can do sepsis in the middle of nowhere with anybody, and if the team knows what they're doing, this is my conclusion to them, then they have the same exact outcome. Right? You don't need to be a big center with centralized and all these things. You can have a peripheral IV, and as long as you know what you're doing, you get the same freaking outcome as a big academic center. Right? It doesn't really change anything. So I don't know. Any more thoughts about this, Jay?
I mean, they made some like minor points throughout the body of the article that seemed kind of obvious, like that basically people who had positive alcohol levels were inaccurately assessed, which we kind of talked about earlier. Like you can have somebody that's awake and talking to you that doesn't have any obvious external injury and have a really bad internal injury, but because they're intoxicated, they may not be recognizing their pain, so they get underactivated, which makes sense. And they also talked about how the BLS team were more likely to transport the patients without alerting them to a trauma, but they can't really comment on whether that's because of lack of experience or like the gray area that differentiates tier 1, 2 from or tier 2 trauma from tier 1 trauma. But I mean, ultimately in the end, they keep harping. For me, the biggest thing they kept coming back to was that they left off these like GCS and like the AVPU scores, but they even there's a sentence right in here that says missing GCS and vital signs resulted in change in the level of trauma activation for only a few patients. So why does it even matter?
Right, it doesn't, because the CDC trauma guidelines were updated in 2011, and the previous update to that I'm pretty sure was either in 2005 or 2006. So, and you know what they did with GCS? They went from GCS of 14 in 2005 to a GCS of 13 in 2011. So, and if you look at their rationale, it was to avoid confusion. That's almost like a joke, like to avoid confusion based upon a GCS of 13. So what, you get one less point for being verbal? That's such in GCS, which doesn't work anyway, right?
Right.
So, I don't know. To me, if your GCS is less than 15, you can go to a trauma center. It's okay, right?
Right. I mean, I guess I would rather
if you have
them-
trauma, right?
I would rather have them overactivate than underactivate, like we're saying, just for patient safety and for so you mobilize all these resources and these people come down, but then the patient gets there and in a matter of 5 minutes you're able to determine whether or not you need all those people, and so they can go back to doing whatever it was they were doing before
Right.
that.
And you don't need us, right? You don't need doctors. I mean, if somebody comes in, they're multi-system trauma, and they don't need an OR, which they probably don't, they need CAT scan, right? Start the process. Don't wait for me. It's just like this works best when, somebody's, you tell your techs to get EKGs on people who walk in the door, and somebody gets an EKG, And you say, why'd you get the EKG? And the tech's like, I don't know, because I was told to always get EKGs. I mean, the answer is, who freaking cares? Do you want to be standing there and assess every patient who comes in the door? Let them get a few EKGs when it's not necessary, right? I don't think you can have it both ways. It's just like the cervical collar. When you ask somebody, why'd you put the cervical collar on? You can't have it both ways. Put a few extra cervical collars on rather than too few, right? It's okay to over triage people. You know, remember when the studies came out with, you know, if you had a gunshot wound in the head, you don't need a cervical collar, right? A bunch of studies on that. So people started saying, well, why'd you put this on? It's a gunshot wound to the head. And you're thinking, this is the case you want to argue about with your EMS, that somebody was shot in the head. And you have the great ability to just take it off if you want and assume the liability. It's totally okay. I read the studies too. It's totally okay. You want the collar off, take the collar off. But, you know, they got you a guy alive who's shot in the head who still has a pulse. Do the usual stuff, right?
Your liability insurance would love you for taking collars off and fitting people for wheelchairs.
Right.
I mean, I think the other thing, like, so their conclusion, like, if you skipped everything in the article and you just read the last paragraph, I mean, they say that, like, ultimately inaccurate information resulted in, or translated to a significantly high under triage rate when injury severity was considered, and that training in these areas may alleviate the problem, especially for BLS crews. So I don't know if it means that we need to change the way we're training BLS. This was only one hospital, you know, and maybe it's better medical control too. Like, if you're the one on the phone telling them, yes, you should or shouldn't call it trauma, then you better know what you're talking about.
So,
you know?
so think about this. If you're the place you trained in residency never got notified except for critical patients, would anything have changed?
Logistically, in some circumstances, if you have a limited number of trauma bays and a limited number of
So trauma will notify anybody sick. We'll notify trauma, STEMIs, strokes, maybe even sepsis. But we're not going to notify you on chest pain, shortness of breaths, stable GI bleeds, asthmas, COPDs. We're not going to notify you because it takes time to notify you. It takes time to get you on the phone. We're only going to play with sick patients. Would anything have ever changed?
probably not, because it's the same thing as them walking through the door and seeing a triage nurse. And,
Right.
You know, someone who's in that waiting room might be
Right.
just as sick or more sick than the person rolling.
And why does it matter what my ETA is to your hospital? I'm probably wrong, right, for what the ETA is. I'm not looking out the window. I don't know where I am. And, you know, and the only reason I ever ask a medic what their ETA is because I got nothing else to say, right? And so it's silliness, right? And I try not to do that. That's why I usually tell the residents, just end the conversation with monitoring transport, because you should say something. But what's your ETA? Like, why does that matter?
10 minutes. Doesn't
Right?
matter.
Yeah.
Or-
I worked in a place that routinely would notify you, and they'd be like, "Oh, we're pulling in right now." So, okay.
All right, so
Great.
you're short of breath. We'll do the usual, the same stuff we've done for everybody else short of breath. But it doesn't really matter. We'll figure it out. What do the lung sounds say? Or I don't know. Are you not going to list for lung sounds when the patient gets here? Right. So why is it? You know, we're doing the usual stuff. You know, when you get there, you'll do the usual stuff. We know what we're doing. Why do we need to have this whole conversation? I mean, somebody once complained about a medic because it was a trauma patient, and they called them and they forgot to, and the doc said, call me back if the heart rate increases, and so I said, well, why'd you say that? And they go, well, maybe the patient was bleeding more briskly. And I'm like, the lights and siren are on. The patient's vehicle. There's a million reasons why the heart rate changes. Yeah. I'd rather them just get to the freaking hospital, you know, if in a multi-system trauma, than call you back, right?
There's a lot of other things going on that they have to think about, and it's just like when we talk about allergic reactions, you need to prioritize the things that are going to make a difference.
This is why for every report, I always say the first line should be, I got somebody really sick or not, right?
Definitely.
Because I got somebody really sick, you got my attention, right? Because they're going to give you a big report, and the last thing somebody's going to say is, and the blood pressure is 50. I used to say this all the time when I was teaching paramedic classes, because when you tell me the last thing the blood pressure is 50, then I go, wait a second, what'd you say? Right, and we sound so stupid when we ask the same questions over. Right.
Wait a minute, what?
And the paramedics get frustrated because they go, I told you that twice. Now I have to tell you a third time. That's what they're thinking in their head. Right, so start out by saying, I got a really sick patient. So like when I call receiving hospitals, the first thing I'll say is, you're getting a really sick patient, right? So somebody hopefully is paying attention, right? It's that one sentence thing, you know, that matters.
That's the hardest thing, is to impress upon the EMS personnel that when you're talking to a physician or somebody on their end, 10 to 15 seconds. You gotta make your case in 10 to 15 seconds.
Same thing with consult.
2 lines.
We all have ADD.
I mean, you
Oh, yeah.
got a lot of things going on, you're gonna be interrupted, people are putting EKGs in front of your face, phone's ringing, paramedic calls in, hey, I got a patient that's crashing, chest pain, no blood pressure.
Right.
Okay, everybody else just hold off,
Right.
go ahead, you know,
Right.
instead of, you know, we went to this house, long driveway, it took us 5 minutes to get up the driveway, a lot of potholes.
Or even if I say somebody,
was friendly.
you're getting a stable asthmatic, and they'll go, can you tell me more about the patient? You're like
Doesn't
why does
matter.
it really matter? It's a stable asthmatic. You're still gonna do the same stuff when they get there if you know what you're
You don't
doing,
need
right?
respiratory. You don't need to intubate.
Right.
That's it.
Right.
That's all you need to know.
I mean, listen, I get in a community hospital where if you don't keep CPAP or BiPAP in your ER, you may need to call. You may need to call respiratory for a vent.
Yeah, but if you say stable asthmatic, that
But-
implies
so-
you don't need that.
I think it depends on who's providing that information to you.
True.
We had one vent for our 37-bed ED community hospital, and the same RT covered OB, which was 2 floors up, and the ED. So it genuinely took 10 minutes to get.
So for you, it's important.
It was
right?
very
Yeah.
important, and I think it comes down to a community resource and like hospital resource availability. If you're going to a large center that is always ready for everything, then I don't think you need to waste anyone's time calling. But in the community hospital where you have 2 docs for 37 beds, they might want to know they're getting a sick patient.
Right.
So I think it all comes down to resource. And we talked about resource and communication earlier. Tagore mentioned it when, depending on who's giving him the information that this patient's alert and oriented, I mean, that really changes. If the paramedic that says, oh yeah, no, they're doing just fine, and then they come in, they're criped in the field. I'm like, what in the world are you talking about?
But as EMS
Yeah, they're good
physicians,
now.
as EMS physicians, we also understand that people can give you a report and they can show up in your ER completely different.
Yeah.
Right.
Right. You know, especially in our population, or most of the time we're telling you the patient's terrible, and when you get there, the patient's stable. And it doesn't mean the patient wasn't terrible 30 seconds ago,
Exactly.
right?
Right.
All right. So good job. We're gonna stop. So where are we next week?
We're back here.
We're back here next week. All right.
The website will
Yeah, we
update.
are.
We'll update the website. Thanks for joining us, and we will see you next week.